Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the 2015 Meaningful Use Final Rule Call. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Peggy Ullman. Ms. Ullman, the floor is yours.
Great. Thank you so much, Laura. Hi, everybody, and welcome to today's webinar. I'm Peggy Ullman from VHQC. We are very grateful for everybody coming to listen to today's webinar on the Meaningful Use Final Rule. Today's session will be recorded, and the recording will be available on VHQC's website within 7 days. Before we get started, I want to tell you a little bit about VHQC. We are a nonprofit consulting firm. We've been around since 1984. We are the Quality Innovation Network Quality Improvement Organization for Maryland and Virginia. We have been the Quality Improvement Organization in Virginia for 30 years, and we've been in Maryland now for about a year and a half. We are also Virginia's Regional Extension Center, so for those of you that are in Maryland, we are the counterpart to CRISP in Maryland. And we provide outreach, education, and comprehensive EHR services to providers and healthcare organizations. We have a lot of dense, detailed information to cover, so I'll turn over my presentation to my colleagues to give you the main highlights from the 700-plus page Meaningful Use Rule, and then we will open it up to question and answer once we have a chance for our speakers to give you an overview. However, I strongly encourage everybody to give the, if you have questions that you want to be addressed during the Q&A, feel free to send them through the chat. And if we don't have time to get through all the questions, we will come up with a frequently asked questions document that we will publish and make available in case your question did not get answered during the call. So we have two speakers today. Jennifer Chenault-Walker is a manager of program operations at Physician Services in VHQC in Virginia. She's going to discuss the modified Stage 2 and what that means for providers, including reporting time periods, Medicare attestation timeframes, and hardship exemptions. And then she's going to turn it over to Paul Cummings, who's the Senior Business Analyst at Chesapeake Regional Information System for Our Patients, which is CRISP in Maryland. And Paul is going to talk about changes to the specific objectives in meaningful use and review the key components of those 10 objectives. So Jennifer, I'd like to turn the floor over to you.
Great. Thanks, Peggy, and thanks to everyone who dialed in today. So as Peggy said, the most recent final rule is over 700 pages long, so we wanted to give everyone an overview and a place to start when they're trying to understand the changes. So one of the most popular and anticipated changes of the final rule is that all providers can report a 90-day reporting period for this year. Some providers are going to have to report on an entire calendar year, but that is no longer the case. And one of the other changes that we're getting quite a few questions about is that providers are attesting to what's now known as a modified Stage 2. This means that everyone has the same set of 10 measures, and everyone must report on all 10 measures unless they qualify for one of the exclusions. So there's no more score measures list versus the menu measures list. All the objectives are required. Providers who were scheduled to report Stage 1 in 2015 or 2016 can use the alternate measures and exclusions as they are detailed in the final rule. But you'll want to pay close attention to the alternates because some are only for 2015, whereas others can be used for 2015 and 2016. And Paul's going to be reviewing the measures and exclusions a little later in the presentation. Let's see. Sorry, I lost my place there for a second on the slide deck. I think I'm actually maybe missing. Can you go back one slide? Go back one more slide. There we go. Okay. Now we're on the right track. The final rule specified also that you need to have your security risk assessment done by the end of the calendar year. That's a little bit different from some guidance that they've given in the past. So if the provider is reporting on a 90-day reporting period, the security risk assessment can be done outside that reporting period, but it has to be done in the same calendar year before the provider attests. So a provider might have already completed their 90-day reporting period in 2015. Their security risk assessment needs to be done by December 31st, 2015. So again, that's contrary to an FAQ that was released earlier in the year. That prior FAQ has said that the security risk assessment could be done anytime up until the day of the attestation. Now the federal rule says you got to complete it before December 31st, 2015 for this year. And also, the attestation portal is not going to open up until January 4th. So at this point, you've got January 4th through February 29th of 2016, actually, to report for a 2015 reporting period. In the past, Medicare has extended that, but we haven't heard of any such attestation extension so far for the 2015 reporting period. So as of now, it's January 4th through February 29th, 2016 that you can use to attest for the 2015 reporting period. Okay, so moving on to future reporting periods, only first-time attesters can use a 90-day reporting period in 2016 or in 2017. And these are providers who have never, ever attested to meaningful use in the past. Everybody else has to use the regular timeline. And in 2017, providers have the option to report on a 90-day period of stage 3. One barrier to reporting stage 3 in 2017 might be whether your EHR vendor has released a version that can report on the stage 3 measures. So if you think you might want to do the optional stage 3 reporting in 2017, you really should start questioning your EHR vendors now as to when they're going to be releasing that version that you're going to need. And you might ask, what's the upside to reporting stage 3 a year before it's required? First of all, because a 90-day period of stage 3 might be easier to achieve than a full calendar year of stage 2 or modified stage 2. And a 90-day reporting period can prepare the practice for the next year in which, 2018 is going to be a full calendar year of stage 3. There's one exception to that, which is that first-time attesters who are attesting under the Medicaid program can still report a 90-day period in their year 1 attestation. Moving on to clinical quality measures, you can continue to report your CQMs manually through 2017. There are some providers who already use eCQMs to submit electronically, but most providers we work with are still entering their CQM data along with their MU measures in the attestation portal. In 2018, that manual option is going to go away, and you'll be required to submit CQMs electronically. So again, kind of all goes back to your technology. If you don't have the functionality right now, that's something you need to contact your EHR vendor to inquire about. It can take quite a while for vendors to create functionality that works, have it tested, and then get it released to all their clients. So it really isn't too early to start contacting your vendors about future technology needs. So for 2015 through 2017, you can continue to use your 2014 certified EHR. There actually are still some EHRs that haven't released a 2014 certified version yet. And if you have one of those older 2011 versions, you're not going to be able to report meaningful use with those reports. You have to be on a 2014 certified version for this year. That's a little bit different from last year because remember we had the flexibility rule that said we can use an older version. Then starting in 2016, you're going to have an option to upgrade to the 2015 certification if that's available to you through your vendor. 2018, everybody's got to have 2015 certified technology to attest. Payment adjustments, as many of you know, already began on January 1st, 2015, and those were for providers who failed to attest in 2013 or who have never attested to meaningful use. And the payment adjustment gets applied to your Medicare Part B claims payments. Remember that payment adjustments are based on the program performance from 2 years prior. And this means if you fail to attest to meaningful use in 2015, you're going to see a payment adjustment of 3% in 2017 on your Medicare Part B claims payments. CMS has a payment adjustment tip sheet online that explains how the payment adjustments work. And because they can be, you really have to think in a prospective way with regards to the performance year versus the payment adjustment year. And we've included a resource pages toward the end of the presentation. And it's got a link to that particular tip sheet. The final rule also encompasses EHR incentive programs through 2017. But 2017 and beyond is called MIPS. So 2017 is the first performance year for CMS's new merit-based incentive program, and that's called MIPS. And that's going to combine meaningful use, PQRS, and the value modifier. And we're not going to be specifically covering MIPS today, but it's definitely something that you need to have on your radar because, again, you have to be thinking about all those things in a prospective way, in a proactive way. VHQC has a lot of really good information, so please feel free to reach out to any of the contacts at the end if you would like some help with those things or if you want some materials about those. There's going to be contact information at the end. And so what happens if you can't attest? Well, if you can't attest due to one of the reasons on CMS's hardship exception application, you can complete that form and return it to CMS. They'll determine if a hardship will be awarded. CMS releases new hardship applications every year, so please don't pull out an old one that you've used previously and just try to resubmit it because it will be rejected. And they do have a deadline, so you may not have time to resubmit to award the payment adjustment. They likely are going to release the next hardship exception application in the first part of 2016. They normally do it after the end of the potential reporting period. The final rule also reiterated that providers cannot be approved for more than 5 hardship applications. I know that nobody on the call is thinking that, oh, they're just going to get out of meaningful use every single year by just submitting a hardship every single year, but they do have something in place that says you can't do this for more than 5 times. So with that, I'm going to turn it over to our colleague Paul in Maryland.
Thanks, Jennifer. Thanks, Peggy, and thanks everyone for joining today. What I want to do in this presentation is give a brief overview of the 10 modified Stage 2 objectives in meaningful use in 2015. Next slide, please. So I first want to talk about the changes to the specific objectives in modified Stage 2. The patient electronic access objective, instead of the 5% threshold, this measure in 2015 requires 1 patient to view, download, or transmit their health data. The secure electronic messaging objective from MU2 has been changed. Instead of the 5% threshold, the measure now requires that the secure electronic messaging capability be fully enabled for the entire reporting period. And then lastly, the Stage 2 Public Health Reporting Objective, this objective in 2015, has been consolidated into one objective with 3 different measures. Next slide. So now, before I dive into the 10 modified Stage 2 objectives, I just wanted to kind of expound on what Jennifer explained at the beginning of the conversation, the beginning of the webinar, regarding the alternate measures and alternate exclusions that are available for providers that are scheduled for Stage 1. The alternate measures, what they do is offer a lower threshold for certain Stage 2 measures that have an equivalent Stage 1 core measure. The alternate exclusions, on the other hand, they are available for certain modified Stage 2 measures that don't have a equivalent Stage 1 core measure. The idea being that since there was no Stage 1 measure for this modified Stage 2 measure, providers can claim that exclusion. So starting off with the Objective 1, Protect Patient Health Information, this measure is also known as the Security Risk Assessment, and it has been around since Stage 1. It's Objective number 1, which indicates CMS's seriousness about having all providers that do meaningful use complete the Security Risk Assessment. So what's required basically for this objective is for providers to encrypt their electronic patient health information, make security updates, as well as correct deficiencies that are found in the Security Risk Assessment. Important thing to note here is that the security risk analysis must occur in the same calendar year as the reporting period, and that there are no exclusions for this measure, for this objective. Next slide, please. Objective 2 for clinical decision support. There are 2 measures within this objective. There's 1 exclusion for measure 2, and there's 1 alternate measure for measure 1. So measure 1 in this objective is implement 5 clinical decision support interventions. The alternate measure, which is available for Stage 1 providers, is to implement 1 clinical decision support intervention. Measure 2 is to enable drug-drug and drug-allergy interaction tests, and the exclusion for measure 2 is available for EPs that write fewer than 100 prescriptions during the reporting period. Next slide, please. So objective 3, CPOE. This is another objective that folks on the call should be familiar with, as it was a meaningful use Stage 1 objective. For measure 1, the requirement is 60% or more of med orders are recorded using CPOE. Exclusion is if you write fewer than 100 med orders. The alternate measure for CPOE is 30% of unique patients with at least 1 med in their med list have 1 ordered by CPOE, or more than 30% of all med orders are recorded using CPOE. Measure 2 within this objective is 30% of lab orders recorded using CPOE. The exclusion is if you write fewer than 100 lab orders. And there's actually an alternate exclusion available here because there is no Stage 1 objective for lab orders using CPOE. Measure 3 under this objective is 30% of radiology orders recorded using CPOE. Again, the exclusion, as with all of the measures under this objective, is if you write fewer than 100 radiology orders within the 90-day reporting period. And again, there is an alternate exclusion available for this measure because there is no Stage 1 radiology objective. Next slide, please. So objective 4, e-prescribing. This objective has 1 measure, 1 exclusion, and 1 alternate measure. So for e-prescribing, you are required for over 50% of your medication, 50% of your prescriptions are queried for a drug formulary and transmitted using the EHR. There is an exclusion for objective 4 if you write fewer than 100 prescriptions, or you have no institutional pharmacy and no pharmacy that accepts electronic prescriptions within 10 miles of your practice location. There is an alternate measure for this objective that is 40% of prescriptions are transmitted using the EHR, and that alternate measure aligns with the measure in stage 1. Next slide, please. So for Objective 5, Health Information Exchange, there's one measure to meet with one exclusion and one alternate exclusion. The measure requires providers for transitions of care. The EP must use the EHR to create a summary of care record and electronically transmit the summary of care to a receiving provider for more than 10% of transitions of care and referrals. The exclusion that is available for this objective is that if an EP transfers a patient to another setting or refers the patient to another provider less than 100 times during the 90 days, there is an alternate exclusion available to stage 1 providers because there is no equivalent stage 1 objective. Next slide, please. So for Objective 6, patient-specific education, with this objective, we have one measure with one exclusion and one alternate exclusion. So the measure requires patient-specific education to be identified by the EHR and provided for more than 10% of all the unique patients seen in the reporting period. The exclusion available here is no office visits in the reporting period, and then the alternate exclusion available to stage 1 providers. This is available for EPs if they did not intend to select the equivalent stage 1 menu objective. Next slide, please. Next slide, please. So for Objective 7, medication reconciliation, there's one measure, one exclusion, and one alternate exclusion, alternate measure within this objective. And the measure dictates that MedRec must be measured for more than 50% of transitions of care in which the patient is transitioned into the care of the EP. The exclusion available is that there are no transitions of care during the EHR reporting period. And the alternate exclusion that is available, providers can claim the exclusion if the EP did not intend to select this equivalent stage 1 menu objective. Next slide, please. So Objective 8, patient electronic access, which we refer to as VDT, view, download, transmit. There are two measures within this objective, one exclusion for measure 2 and one alternate exclusion for measure 3. So measure 1 requires over 50% of patients to be provided timely access within 4 business days to view, download, or transmit their electronic health information. Measure 2 requires at least one patient to view, download, and transmit their health information. The exclusion for this measure is if the EP neither orders nor creates any of the information that's listed within this measure, or 50% or more of your patient encounters occur in a county with less than 4 megabits per second broadband availability, which I expect applies to anyone in the alternate exclusion. Yes?
You're breaking up. I don't know if there's a way for you to get closer to the phone, but your voice is sort of in and out.
Okay, is this better?
Yes.
Okay, great. Yep, I think my microphone was a little far away, so thanks, Peggy.
Thank you.
So picking up on measure 2 of the VDT objective, there is an alternate exclusion for measure 2 due to the fact there is no stage 1 objective for a patient access, patient viewing, downloading, or transmitting their health information. Next slide, please. So Objective 9, secure electronic messaging. With this objective, there is one measure, one exclusion, and one alternate exclusion. And so for this measure, CMS is requiring the secure electronic messaging capability to be fully enabled for the entire EHR reporting period. The exclusion is that there are no office visits during the EHR reporting period. And then there's also an alternate exclusion available because there was no meaningful use stage 1 objective that would be equivalent to this modified stage 2 objective. Next slide, please. And objective 10. So objective 10 has 3 different measures. This was one of the changes I mentioned at the beginning of my presentation. There are 3 measures, 3 exclusions, 1 alternate specification. Alternate specification is that if the EP was scheduled to be in stage 1 in 2015, you only need to meet 1 measure. And for Maryland, likely that measure is the immunization registry submission. In Maryland, VHMH does not currently accept syndromic surveillance submissions from EPs, except for EPs that are practicing in an urgent care center. So most Maryland EPs are excluded from the syndromic surveillance requirement. So for stage 1, if you're scheduled to test for stage 1 of meaningful use in 2015, you must, like I mentioned, you must meet 1 of the 3 public health measures, likely immunization, unless you can be excluded from all of the measures. So if the EP is in active engagement with VHMH for immunizations, you're going to pass the objective. Active engagement is defined as either completed registration in testing or validation with VHMH or in production. If EP can claim an exclusion for the immunization, you'll need to meet a specialized registry if that registry is available and applicable to your practice. If you're in stage 2 in 2015, you must meet 2 of the 3 public health measures. These will likely be immunization and specialized registry in Maryland. The same exclusion logic is going to apply here that it does in stage 1. So if you're in active engagement with VHMH for immunization, you will also need to meet specialized registry. If you can claim an exclusion for immunization, you'll need to meet specialized registry, obviously if the registry is available and applicable to your scope of practice. But if no measures remain available, you are able to meet this objective by claiming applicable exclusions for all the measures. And so VHMH is planning to release some further guidance on Maryland's available specialized registries, including the current cancer registry and the prescription drug monitoring program, PDMP. VHMH is also considering some flexibility with this measure. They're currently working with CMS for potential flexibility, obviously pending CMS approval. Likely will be communicating this to providers in Maryland in the coming weeks and months. So stay tuned for some more guidance regarding the public health measure in Maryland. And I just wanted to add, I don't have a slide here for how to contact CRISP support for Maryland-specific meaningful use questions. Our toll-free hotline is 877-952-7477. So if you have any Maryland-specific questions that you're having trouble with, we work very closely with VHMH, and we'll be able to answer those for you. You can also contact us via our email address, which is support@crisphealth.org. And that wraps up my presentation, Peggy.
Okay, great. Thank you, Paul. Well, we've got a ton of questions in the chat. Before we go to the questions, however, one question that was relevant, actually, Sandy, if you could go back to the slide about the immunizations. We had some questions about how it works in Virginia, and I wondered if Jennifer could address that, because Paul was focusing on syndromic surveillance in Maryland.
Sure, Peggy. In Virginia, we have an immunization registry, we have a syndromic surveillance, and we also have a cancer registry. And on the Virginia Department of Health website, that's VDH, they actually have a meaningful use page, and they've got a user guide as to how to complete the registrations. So if you register for any one of their registries, they get your data, they'll contact you, and as long as you register and, reply back to them in a timely fashion, you are considered to be in active engagement and could meet the measure. If you're questioning whether or not your specialty would apply to, say syndromic surveillance or the cancer registry, they can help you weed out, which providers they're onboarding right now, whether or not this may not even apply to you, that kind of thing.
Okay, great. Laura, could you give directions for how to call in with a question? And then while we're waiting for callers, I'll start with a bunch of the chat questions. And again, we'll try to get through as many as we can. And what we're not able to get through, we will follow up with a response in a written document.
Certainly. The floor is now open for questions. If you have a question, please press the number 7 or the letter Q on your telephone keypad. Questions will be taken in the order that they were received, and if at any point your question has been answered, you may press 7 or Q again to disable your request. We do have 2 questions that have come in. Norton Elson is on the line. Norton, please go ahead.
Thank you. Could you put up the slide again of Objective 9? There's a discrepancy between what I have here. Here we go. So in 2016, I see what the difference is between what I was looking at and what you have. For 2015, we don't have to have anybody actually using the secure messaging, just have it enabled. That was for 2015. For 16, one person has to use it. But the current year, it just has to be enabled. Is that right?
That's correct. So the current year in 2016, the secure messaging functionality needs to be enabled. In 2016, at least one patient will need to send and receive a secure electronic message. And in 2017, it bumps up back up to the 5% threshold that was originally in previous stage 2.
Okay, great. I didn't catch the years. Thank you.
Our next question comes from James Dawson. James, please go ahead.
Hi, James Dawson from Advanced Primary. My question here is around objective number 5, the summary of care. It indicates that 40%. Is that 40% of the office visits within that reporting period?
So for Objective 5 Health Information Exchange, the measure is 10% of the transitions of care and referrals.
Okay. So it's 10%, thank you.
You're welcome.
And again, if you do have a question or comment, you may press the number 7 or the letter Q on your telephone keypad.
Okay, I have a question for Jennifer. This is about Virginia Medicaid. Someone has asked, can you speak to the Virginia Medicaid program and their decision to not adopt the modifications until after December? This poses quite a challenge for those of us with duly eligible hospitals that will be attesting for 2015. They physically cannot meet the initial deadline for the Medicaid program due to CMS not opening the portal back up until January 4th.
Yeah, so if they're testing under the Virginia Medicaid program, they're currently working on making changes to the portal. They got the final rule when everyone else did, so they have to do all their, coding and programming to make things work properly so that people can properly attest. That's probably the major reason why you're not going to be able to attest under the new changes until December. And also, CMS has said that if you attest to a 2015 reporting period, you might see the payment adjustment modifier on your claims, but those claims will be reprocessed after your attestation is received and processed. So, yes, you might see the modifier on your claims, but I would recommend keeping track of those claims that you feel are going to be subject to the modifier so that you can make sure that those get reprocessed.
And we have had similar conversations with Maryland Medicaid, and again, they're sort of in the same boat, and one of their responses was, part of their response is that, CMS has been working on these final rules all along, and they have had time to revise their portal accordingly. The states, unfortunately, did not see the final rule till the rest of us saw it, and so now they're scrambling to adjust all of their coding to make sure that they can help providers successfully attest, because it would certainly be worse if people try to attest and then it fails. Do we have any other questions on the phone line?
We do. We do have a question from Liana George. Liana, please go ahead.
Hi, thank you very much. I'm Dr. George from Virginia, and my question is regarding the number 7, regarding medication reconciliation. It takes more than 50% of transition of care. My question is it only for the transitional care code which we use, or is it for all the new patients, which we are seeing for this 90-day period, or is it for all the patients?
Sorry. As I understand the question, is for Objective 7, EP performs MedRec for more than 50% of transitions of care, in which the patient is transitioning to the care of the EP during the 90-day reporting period.
Yeah, my question is like in a transition of care, there is a special code which we use for the CPT 99495 or 99496. But if I see a new patient, will it be considered in that transition of care? But it's a new patient, a new Medicare patient. I'm a primary care physician. That's the part I didn't understand. Is it for all the CPT codes like 99203 or 99214, like a patient coming for a follow-up, like a regular follow-up 99213 or 214, will it be included in that eligible number or just the transition code, new patient?
Sorry, Peggy, is there anyone on the VHQC team that can address that question?
Yeah, this is Jennifer. So the transition of care within your EHR isn't triggered by your CPT coding at all. There should be a separate checkbox in your office visit where you designate what a transition of care is. So you get to designate whether this particular visit is a transition of care or not. So what you want to do is contact your EHR vendor if you're not sure where that checkbox is, and they can help guide you. Transition of care is really defined by CMS as the movement of a patient from one setting of care to another. So you're right, some of your new patients are going to be a transition into your clinic, and you may want to do a medication reconciliation if you've never seen them before. If they've been in an inpatient setting where their meds have likely changed and you see them back, you might want to designate that as a transition of care. But that's for you to designate separate from your billing codes.
Oh, okay. Thank you very much.
Sure.
Okay, I want to go back to the chat. There are quite a few questions in chat, and again, we're going to try to get through all of them. There was a question about, can you speak to what providers like diagnostic radiologists will be expected to do once the 5 hardship exemptions have been granted, but they still don't see any face-to-face encounters?
Yeah, so that I would need to pull up the hardship application, but I believe that radiology is specifically exempted from meaningful use. And if that person could email Peggy their information, I would be glad to just verify that and get back in touch with them. But I think that's one of the specialties that is recognized that it's going to be exempt from meaningful use.
Okay, great. I had a question about, can you provide clarification on the definition of externally credentialed staff? Is this going to change from 2015 to 16 or 17?
Yeah, I'm not familiar with that specific definition. So again, if that person could email Peggy that, what they're referencing, I think I'll be able to speak better to that specific scenario.
Okay, that would be great. And you can send me a message through the chat. And my email address is also at the end of the presentation, which we'll spend the last couple minutes on, but there's a lot of questions in chat, and I want to make sure that we're trying to address them. Is the 90-day reporting period also for Stage 1, Year 2?
Yes, so the 90-day reporting period for 2015 is for everybody.
Okay. Is the e-prescribing measure the previous H205 menu set measure with increased threshold from 10% to 50%?
So with the e-prescribing objective, in Stage 1 it was just the prescriptions are transmitted using the EHR, and I believe the drug formulary was siphoned off into a different measure, but I'm not positive. But I believe that it's the same, the in-depth details of that electronic prescribing measure was the same as it was in Stage 1.
So the threshold has not increased as far as you're aware?
The threshold has increased. So I believe it's 40% in Stage 1, and now in modified Stage 2 it's 50%.
50%, okay. Laura, do we have any questions on the phone?
We do have a follow-up from James Dawson. James, please go ahead.
Thank you. Well, I actually have two questions now. Thank you. The first question I'd like to ask is that you keep referring back to Stage 1 and Stage 2. I'm under the impression that there's no such thing as Stage 1 anymore. It actually is a modified Stage 2. Am I correct by making that statement? And then my second question is, in my practice, we have two PMR physicians, physical medicine and rehab, and they prescribe narcotics. Are we going to be penalized for them not using e-prescribe because they cannot send narcotics to electronic prescriptions?
Hi, this is Jennifer. I will address that. So you're correct. Everyone is under modified Stage 2 this year. However, providers do need to know what they normally would have been responsible for attesting to, because some of those Stage 1 exclusions and alternate measures might apply for them this year and next year. But yes, everyone is attesting under modified Stage 2. So the second part of your question about the narcotic prescriptions, to this point, you should have a setting on the back end of your EHR which will exclude those prescriptions, which must be handwritten. And so you can contact your EHR vendor if you feel like that is not, checked off on the back end of your system, so that those prescriptions won't count in your denominator and they won't count against you. And I just also wanted to add that, at least in Virginia, there really is a movement to start sending e-prescription or narcotic e-prescriptions. And so that is on the horizon. So it's something just to continue to be aware of moving forward.
Okay, great. Another question that we have in chat is for Objective 10, Stage 2 in 2015. If you are doing immunizations, can you count your second one as exclusion for syndromic surveillance?
I remember that. I mean, yes, if syndromic surveillance does not apply to you, you can count it as an exclusion, even if you're doing the immunization reporting.
So as long as you can meet one measure and then you can be sufficiently excluded for another measure of the three options within that measure, then you've successfully met Objective 10? I think that's what they're asking.
Oh, okay. So if you were scheduled to report stage 1, you only have to, attest for one of those things. So if you get a yes for immunization, that's your 1.
Okay. And if you were scheduled to be in stage 2?
If you're scheduled to be in stage 2, you need to either report 2 of those or you need to show the exclusions for all of them.
Or report 1 and then the exclusions for the other 2 if that happens to be the case?
Yeah.
Okay.
That's right.
Okay. All right. Hopefully that helps. And I think we had some questions about the Virginia and the Maryland immunization registries. Just to keep in mind for the audience, we do serve both Virginia and Maryland, and while there are, a lot of this stuff is nationwide, there are certainly around the issues of immunization registries, there are definite differences between how Maryland operates and how Virginia operates, and hopefully we've adequately addressed both of those. There was a question about can DHMH accept syndromic surveillance for urgent care facilities?
So I believe so. As I mentioned, DHMH will be communicating to providers in Maryland with some more specifics about this measure. And I'm actually not sure how the syndromic surveillance for urgent care facilities is going to work at the moment. But if the person that asked that question can follow up with Peggy, we can be sure to get you on our distribution.
Okay, great. We have a question about Objective 5, Health Information Exchange. It says the Federal Register on October 16th shows an update that says that the summary of care record can be transmitted electronically. Does a fax transmission count?
This is Paul again. I'm not positive about if the fax transmission count. I know that the transmission does not need to occur using the EHR technology. It can occur using any electronic method. I would think that a fax being electronic would count, but I would need to consult the final rule on that question.
Okay. Laura, are there any other questions on the phone lines?
We do not have anyone queued up at the moment, but if you do have a question or a comment, please do press the number 7 or the letter Q on your telephone keypad.
One question in chat is there a limitation on the number of exclusions that a stage 1 provider may take?
Jennifer, I'm not sure if you're aware of this. I'm not aware of any limitation for exclusions as long as you have documentation that you have met the exclusion. I'm not aware of any type of limitation.
Yeah, that's how I read it, Paul, was that's something we were specifically looking for to see if they would put a limit on the exclusions and to my knowledge, if you qualify legitimately for the exclusions, you can report the exclusion as long as you have the documentation to back it up.
Okay, another question I have is whether someone wants to know if there are specific guidelines to the security risk assessment.
So I can take that one. Yes, there are specific guidelines for Objective 1. They are obviously they're within the Federal Register, and you can see them here in 42 CFR. This highlights everything that you need to do with your security risk analysis. If you can see on the screen, you would access that documentation to find the guidelines. There's also very helpful tools that ONC has published regarding doing your own security risk assessment. Those can be found on healthit.gov, and many of the practices that we support have used those resources to conduct their own security risk assessment.
Okay, and to clarify, the 45 CFR that's referenced here, that is something that somebody could go to the Federal Register and search that, and it would pull up the regulation, correct?
That's correct. So yeah, if you type in this 45 CFR code into a search engine, you will be connected to the Federal Register where the rules are written, and they'll have all the specifics there.
Okay, great. There's a question. I'm sorry, right?
I apologize, Peggy. I was just letting you know we do have 3 questions on the line. I'm not sure if you would like to go there.
Yes, let's take the questions on the line because the ones in chat we can follow up with via a frequently asked questions document. If you are on the line and we don't get to your question, please either email it to me or send it to me in chat. And then also, you'll see that the polling questions have popped up. If people are checking out early, we just want to make sure that you do the polling questions because that's very, very helpful to us in terms of planning future webinars. So I would like to start with the 3 questions that we have and then see how far we can get, and we'll go back to some of the chat questions if we have time.
Okay, excellent. We do have a question on the line from Chris Ray. Chris, please go ahead.
Hi, can you hear me?
Yes.
Okay, this question is for Paul. Paul, for the stage 2 in the state of Maryland for objective 10, in those 3 objectives. So first objective, working with the DHMH, that kind of takes care of that. Second objective, we can apply for an exclusion because DHMH is not ready with this survey, syndromic surveillance. So I want to clarify the stage for the objective 3, which is special registry. So you were saying that the DHMH soon will be coming up with that, and as long as we start working with them, we are okay. Am I right on those 3, what I said just now?
Yes, what you said was correct about the immunization, the syndromic surveillance, and then the specialized registry. So DHMH currently operates a cancer registry. Obviously, if that's outside of the scope of your practice, you won't be able to utilize that. DHMH is considering utilizing the existing prescription drug monitoring program, PDMP, as a specialized registry, but those discussions with CMS aren't finalized yet. So Chris, if you want to send us an email at support@chrishealth.org, we can be sure to keep in touch as soon as the guidance from DHMH is released on the specialty registry. Okay, so still then just hold off, Until then I would just hold tight. Okay, thank you.
Our next question comes from Lori Dodson. Lori, please go ahead.
Yes, I'm just a little confused about, we plan on attesting to stage 1, year 1 in January for 2015, but did I understand you correctly say that people will not be attesting under stage 1, it's going to be a modified stage 2, so I'm not going to be testing under stage 1, is that correct?
Yes, that's correct. So the modified stage 2 includes the 10 objectives that Paul reviewed, and those are the objectives and measures that everybody has to attest to. That is correct.
Thank you.
Our next question on the line comes from Monica Cambanari. Monica, please go ahead. Could you pull up objective number 6 again? And when this says patient-specific education resources identified by the EHR, what exactly does that mean?
So I can jump in here. The patient-specific education resources would be certain educational information that are related to conditions that the patient has. So, for example, there's information regarding hypertension or smoking cessation. Those would be 2 examples of patient-specific education.
So I'm in a pediatric office, and we give handouts to our patients when they take the well-child checks, but our EHR doesn't generate that. So would that be considered meeting that measure?
So I believe that the measure is really focused on the fact that the resources are identified by the EHR system. The fact that they're not generated by the EHR, I would just need to look in and double check the final rule on that one, unless VHQC has some further insight into that.
Yeah, you previously you could use paper resources and those all would count, but I believe under the new final rule, those types of resources no longer count. But again, if you'll send your contact information in, we'll just verify that and make sure that that's correct.
You're actually breaking up, so I didn't understand the last part of what you said.
Oh, sorry. I believe that paper resources handed to the patient used to count previously, but under the new final rule, they do not count any longer towards your numerator. And so, but I want to verify that. So if you could send your information in, I'll verify that, and we'll get back in touch with you with an affirmative answer.
Okay. Thank you. Okay, and I would like to ask that if people are sending their email address in because they want a specific question addressed, if you could just remind me what your question was in the chat, because it's sometimes a little hard to remember who asked what question or what information they were looking to find out. It's 12:57. I want to see if we have anybody else on the phone line, and if not, maybe I can address one more question within the chat, and again, we'll follow up with a frequently asked questions.
We do have 3 people queued up for questions.
Oh boy.
Go ahead, I'm sorry.
No, go ahead. Let's try to get through. Let's try to get through and do this. Just Sandy, could you go to the page with the with all of our pictures on it that has our email addresses? So if you have questions, here is my email address for the Maryland providers. Kelly Linello would be your best contact for Virginia providers, although you could send it to me and I can forward to Kelly. And if it's related to Virginia or Maryland hospitals, you can send them to Sandy Gaskins. We will stay over a little bit to try to get through these 3, the questions that are on the call, but if you need to hang on, if you need to jump off, I wanted to make sure that people had these email addresses available to them. So can we go to the first question on the phone line?
Sure. We do have a follow-up from James Dawson. James, please go ahead.
I'm sorry, it looks like I'm hogging the whole conversation. I just want to make a comment about the secure messaging. I just recently went to a certification for HIPAA, and they are suggesting that faxing is not a secure means of transmitting medical information. Just want to kick that out there to people. So definitely check their HIPAA compliance guidelines if they are not recognizing that as a secure means of messaging.
Okay, thank you for that information. Well, that is something to consider, and I think that Jennifer was going to look into that question and get back to the caller about that one. Is there another question on the line?
Carrie Trevor, please go ahead.
Yes. Okay, my question has to do with the CMS documents that were put out on the CMS website. There was a separate page for each of the 13 core measures. Now we do have a 2015 tip sheet for the new 10 objectives. Is there a separate page for each of the 10 objectives that has the detail that we need?
This is Paul. I believe CMS is going to be releasing specification sheets, which you're probably familiar with those that were around with meaningful use stage 1 and stage 2. And those specification sheets go into a lot more detail on each of the objectives and measures. I'm not sure what their
timeline on releasing those are. I'm not sure if anyone else has insight into that.
Okay, I know that they're going to be developing those, or they are developing those, but I don't know when they're going to be released.
Okay, but we know they haven't been released. I should quit searching.
Correct. Yep. You got it.
Okay, and then there was one more call on the line.
We did have another person with a question. However, they have dropped off, so we have no further questions on the line.
Okay, great. I know there are quite a few questions that we did not get to in chat. We will have a record, as I mentioned, we do have a record of these questions. Thank you, everybody, for an incredibly interactive conversation. This was a lot of detail, a lot of information. So we will be following up with this frequently asked questions document that we will circulate to everybody that registered for the call, as well as anybody whose email addresses were sent to me via chat or via email. If you don't think that if you never got the slides originally, then you did not get the registration. I'm not sure that we have your correct registration information, so if you want to be included on this frequently asked questions document and you have not sent me your email address today, please send it to me at poehlmann, POEHLMANN, at VHQC.org. Thank you very much to our speakers for putting together such a very detailed and informative presentation, and I appreciate everybody taking an hour from their day to listen in. Thank you very much.
Thank you. This does conclude today's teleconference. We thank you for your participation, and you may disconnect your line at this time.